after defecation question comes in your exam, make this diagram. Remember there's two fucking nose. Pelvic and pudendal. Pelvic is the one that carry, which is efferent. Efferent is pudendal. So what is the reflex phenomena with voluntary control? It has both reflexive and voluntary components, right? Both reflexive and voluntary components. Center for defecation is present at the sacral level of the sacral portion of the spinal cord, which is influenced by the higher centers. Stimulus, defecation, flex initiated in mass peristaltic movement of the descending and sigmoid colon pushes the colonic container to the rectum. As the external inner sphincter is innervated by somatic nerves, the voluntary effort is also important. What is the stimulus? Stimulus is the mass peristaltic movement of the descending and sigmoid colon, pushing the colonic content into the rectum. Now the external sphincter is under the control of voluntary, therefore voluntary effort is also important. However, normal defecation, the factors defecation is inhibited by acute anorectal angle, which is about 90 degrees, and contraction of external sphincter and puborectalis muscle. Now, pathway receptors, stretch receptors in the wall of rectum. Efferent receives this efferent via pudendal from rectal comes here. Efferent input from the spinal to rectum and internal sphincter comes where? Okay, yeah. Efferent input to the rectum and the internal sphincter comes via pelvic nerve, whereas to the external sphincter comes via somatic nerve. Higher centers influence spinal cord via corticospinal pathway. Mechanism: increase in intra-abdominal pressure, relaxation of external sphincter muscle, decrease in anorectal angle, and relaxation of puborectalis muscle. Deep breathing, push the diaphragm downwards, which increases the pressure, relaxing whatever. What applied reflex in the transection of the spinal cord. Voluntary defecation control is lost, but it can be achieved by activation of mass reflex. And there is some applied disease. It is congenital megacolon. Megacolon, why? Because of distension of the colon due to because the enteric nervous system or plexus, neuronal plexus is absent in that section. It usually occurs at the distal part of the colon and causes distension of it, accumulation of feces. Inhussion's disease, entire neuronal plexus is congenitally absent. Both mynteric and submucosal plexus is absent. Feature abdominal distension. Treatment is usually surgical dilation. Now, irritable bowel syndrome. This condition, irritable bowel syndrome, is known as, a question can come as spastic colon, mucus colitis, irritable colon, and colonic neurosis. In the West, 20-30% of gastrointestinal disorders are constituted by IBS. What is IBS? It is a functional disorder of the intestine characterized by alteration of the bowel habit and abdominal condition. irritable bowel syndrome. The functional disorder of the intestine characterized by alteration of bowel habits. So second detector organic pathology. There is no pathology, there is no morphologic, histologic, microbiologic or biochemical abnormalities. IBS. No morphological, no microbiological or histological. No matter. Emotional stress. Electrical abnormalities and the clinical features. Electrical abnormalities, now we know BER and spike activity. In normal, we will compare the normal electrical activity and normal electrical activity in the GIT versus in the affected individual. So in normal people, feeding induces spike activity immediately, which peaks in 30 minutes. And lasts for 50 minutes. But in IB is induced. In normal individuals, feeding induces the peaks in 30 minutes, lasts for 50 minutes, whereas in the affected individual it dampens in the first 50 minutes, but it becomes stronger later on. Clinical features: in India, the female to male ratio is 1:3, though in West, females suffer more. The clinical spectrum is wide. The presentations include painless functional diarrhea, simple constipation, alternating diarrhea and constipation, bloating of abdomen, painful spasm of colon and small intestine. Common age 20 to 40 years of age. Symptoms are vague. These symptoms include abnormal bowel habits, ranging from constipation to diarrhea, often alternating irregularly, pallid-like stools, increased gastrocolic reflex, vague abdominal pain ranging from dull ache to severe colic flatulence, relieved by belching, capricious appetite, and insomnia. All patients are emotionally tense and they tend to exaggerate Now, inflammatory bowel disease, Crohn's disease and ulcerative disease. Crohn's disease is usually just affects one part of intestine, whereas ulcerative may affect the entire large intestine. Crohn's disease has a cobblestone-like structure internally, where it is ulcerative structure. It is an idiopathic. It is idiopathic chronic ulcerative inflammatory bowel disease. Idiopathic because its reason is not so known. So chronic, it is chronic ulcerative idiopathic. It is idiopathic, chronic and ulcerative IBD, characterized by transmural and non-scissating granulomatous inflammation, affecting giving a cobblestone structure-like feature, affecting most common segments of terminal ileum or colon, though any part of gastric. Ulcerative colitis can be acute and chronic uroinflammatory colitis. It is colitis, so it's definitely so information of colitis. It affects the mucosa and some mucosa of the rectum and descending colon. Sometimes it may involve the entire length of the large bowel. Okay, second, third. Okay.